Good afternoon, everyone. My name is Aura Go, Project Coordinator at the Mental Health Foundation Australia, and your host for today's webinar. We begin by acknowledging the Wurundjeri Woi Wurrung as the traditional custodians of the land on which our office stands, and pay our respects to their elders past and present. We extend that respect to any Aboriginal and Torres Strait Islander peoples tuning in today. On behalf of the Mental Health Foundation Australia, I would like to welcome and acknowledge our distinguished guest and member of our Scientific Advisory Committee, Professor Jayashri Kulkarni AM, who is presenting today's webinar on hormones and women's mental health. Thank you to Dr. MGR Educational and Research Institute for partnering with us to develop this webinar. And of course, I also welcome and thank all our audience members for tuning in today. Before we begin, I would like to introduce our presenter. Professor Kulkarni was appointed Professor of Psychiatry at the Alfred and Monash University in 2002. She founded and directs two research centres, the Her Centre Australia and Monash Alfred Psychiatry Research Centre. Additionally, she heads the Department of Psychiatry at Monash University's Central Clinical School. Internationally recognized as a leader and expert in the field of women's mental health, Professor Kulkarni's groundbreaking clinical research on reproductive hormones and mental illness has led to the development of innovative treatments for women with mental ill health. In September 2021, Professor Kulkarni developed and launched Australia's first women's mental health hospital at Cabrini Health in Elsternwick. In acknowledgement of her outstanding contributions to medicine, Professor Kulkarni was honoured with an Order of Australia AM in 2019. So please join me in welcoming Professor Kulkarni for her presentation.
Thank you. Thank you very much. I'm very grateful to the Mental Health Foundation for all the work that is done in so many different ways. And also I'm very pleased to be here presenting on hormones and women's mental health. So I do apologise in advance that I wasn't quite sure of the disciplines that the different attendees come from. So I apologise in advance if it's too simple or is too focused on one area, but I'm happy to take questions about other things. So just quickly about Her Centre Australia. This is a Monash University centre, and we have two main collaborators, Alfred Health and Cabrini Health. The aims of our centre are to provide health services, education and research in women's mental health. That's where Her comes from, health, education, research. We do this in a multidisciplinary manner with co-design and input from women with lived experience. I must also say, very importantly, that we take an inclusive approach and we consider the term women to include any and all who identify as a woman. So why women's mental health and what's different about women's mental health? The past 3 years has seen incredible new activity and a lot of activity by women to end violence against women. In fact, there was a walk today, a march today in Melbourne about ending violence against women. And there are some very sad statistics that are still occurring in terms of violence against women in our society and in societies around the world. Again, people are fighting for women to have reproductive rights in places in the world, such as the USA, which we would be surprised to learn that, of course, the reproductive rights have gone backwards in what is available. I mentioned the huge marches for justice, and there was one again today, but the general feeling that many women have is that time's up to be inactive in this area. So the current social activism is worldwide, and again, there are many, many marches and all sorts of protests that are about making the world safer for women and making their women's voices heard and better representation for women in all sectors. In psychiatry, in this context, there is a big sense that women are saying enough is enough, that women's voices have not been heard in the practice of traditional psychiatry and a lot of different areas of medicine, and that the time is up for inaction in this manner. Why in particular is women's mental health critical? Because the mental disorders that represent the leading cause of disability and the highest burden of non-fatal illnesses for women in Australia are mental disorders. 47% of women in Australia, 3.5 million, have experienced a mental illness at some time. And of course, COVID impacted women's mental health enormously. There was a big rise in the numbers of women with depression, anxiety, post-traumatic stress disorder, eating disorders, and alcohol use disorder in this country, in Australia, as well as many other places around the world. In fact, global surveys commissioned by the World Health Organization actually showed that the impact of COVID was the most significant on women across the world in an economic way, in a power dynamic way, in terms of violence against women, and in terms of mental health issues. So for all sorts of reasons, women's mental health is a really important area to think about as separate from other mental health. The cost of mental illness is quite incredible, and this is an estimated old cost, so obviously the latest figures are going to be more than this, but about $32 billion a year is lost in productivity, and that's direct productivity, which is about, actual not being able to work. When you add in the indirect cost, that's cost of treatment, lost earnings, the cost of loss of effective parenting of children, divorce, the loss of care of elderly parents and parents-in-law and others, this all adds up to a huge burden on the economy. And of course, that's not taking into account the humanitarian aspects, which are indeed enormous. So where to now for women's mental health? What are we going to do? Well, it's important to adopt a different model for women with mental ill health. I actually think a holistic model is good for everybody who has a mental health problem, but in women in particular, the integration of social factors, biological factors, and psychological factors are absolutely critical, because each one of these domains affects the other domain. So social factors have a direct bearing on the psychology and also the biology, and the circle goes round. So a holistic model is really critical to consider when we think about what are we going to do that's different for women with mental ill health. So some specific areas that we can think about is to change the status quo, change the current way that we think about mental health. And I would put a plea in here for neurobiology or brain biology, because it's an area that by and large has been overlooked in mental health, but in particular in women with mental health conditions. Hormones, such as gonadal hormones, particularly, that's estrogen, progesterone, testosterone, are really critical in mental health impact. And it's something that is not very well known. It's something that's not very well discussed. And it is something that doesn't come into treatment modalities. Some of the diagnostic categories from traditional psychiatric terminology is not helpful for women. So I'll talk a bit later if I get a chance, because I've got a lot of material, but some of the personality disorder categories, for instance, histrionic personality disorder, borderline personality disorder, these are things that are stigmatizing for women. And by and large, women get those diagnoses, and it does disempower what they are observing in themselves and what help they need. I think also many of the therapies have not really got a woman-centered approach. So many times the therapies are inherited from bygone era where there is not a female empowerment strategy behind the psychological therapies that are in common usage. We definitely need more research, and we need more women-specific services. So as Aura said, I started the first women's mental health hospital in Melbourne, or in Australia, and I started in Melbourne only 2 years ago. So this is not a particularly difficult thing to envision that women needing inpatient treatment would do better in a unit that actually kept them safe and private, and that they didn't have to face the abuse and the things that go on in current day in our wards and situations where you've got co-gendered wards. Also, we have written up new therapies that are female empowerment strategy based, which means that then the targeted work that is done in therapy is very female specific. So again, we're calling for more education of health professionals about the special needs for women, and also that the general public need to have more information about what is different and what can be done differently for women's mental health. Today, again, forgive me, I've got the topic hormones and mental illness, so I'm going to go down a specific pathway, although obviously I would like everyone to remember that all the mental illness conditions have a social context and precipitating, perpetuating factors in the woman's environment, as well as the psychological context. So while I talk about hormones, it is specific biology, I want you to keep in mind that this is a biological plus psychological plus social concept. I'll talk a bit about PMDD, that's premenstrual depression, perinatal mental health a little bit, perimenopausal depression, and this condition called complex post-traumatic stress disorder in women. So the fundamentals of the hormone that we're talking about, one of the key hormones, women's hormones, is estrogen. And estrogen is a potent neurosteroid, a potent brain hormone. And we have tended to forget that. It tends to be that the gonadal hormones like estrogen, progesterone, and testosterone are only considered to have an impact on the reproductive organs, uterus and the ovaries and perhaps breast tissue. But that's only a very small part of what these hormones do. Even more importantly is their role in the brain. And we have forgotten that. So it is important when somebody talks about mental ill health, a woman talks about it, that we think about whether this could be related to hormonal shifts that we see in the pregnancy, premenstrual period time, and also around menopause. Estrogens are not just one thing, and I say they're a plural, and there are many different types of estrogen. So there's one called E1, which is estrone, and it's most abundant in the ovary and also adrenals. Estradiol is the most potent, and it's from the ovaries. And then estriol is a third type, which is produced in the placenta. So I don't expect you to memorize this chart, but it's just to show you about the interaction between the progesterones, the androgens or testosterones, and of course the breakdown product of testosterone is estrogen. So testosterone is broken down to estrogen. So again, these things are really critical when we think about the continuing hormonal flux that goes on in normal situations. Also, estrogen receptors are everywhere in the body. And again, we must get away from thinking that estrogen is purely about reproduction. It is not just ovaries, uterus, and breast tissue, but it is everywhere. And in particular, you'll see in the central nervous system in the brain that the alpha and beta types of estrogen receptors are everywhere in the brain, as well as in the body. So again, we can look at things like imaging of the brain, and we find that in fact estrogen is very important in all sorts of higher cognitive or more complex thinking functions. And estrogen is actually very diffusely spread in a number of different areas in the brain, showing again that it has many roles in thinking, emotion, and behavior, particularly in women, but also in men. Within the brain, estrogen is known as the neuroprotective agent. So this is the good guy in terms of the brain. And it does this by several mechanisms. One is a genomic or delayed mechanism. The other is through preventing cell death, through sprouting axons, which are the connections between cells, and regenerating cells, as well as improving the synaptic transmission, that's the communication between cells. So all of these effects combined give it the neuroprotection name or role in the brain. So estrogen is a neuroprotective agent. What else does estrogen do? Well, for those who are familiar with psychiatric drugs, for example, we know that many of the psychiatric medications work on the dopamine system and the serotonin system. A number of antidepressants, SSRIs, like Prozac, are serotonin modulators. And so here is an interesting known fact that, in fact, estrogens are also very potent in driving and modulating these same brain chemicals that are implicated in different conditions. So, for example, serotonin is implicated in causing depression and also hallucinations in people who have schizophrenia. Dopamine is implicated in the symptom of delusions. The cholinergic system, that's acetylcholine, plays an important and large role in memory, and estrogen influences all of these. So it's as if in estrogen we have like the big mama of hormones that then controls a whole range of other activities. So we know a lot about estrogens in the lifetime of mental illness. So, for example, women with postnatal depression, including those who were resistant or didn't respond to antidepressants, have shown significant improvements after receiving transdermal or skin patch estrogen. Similarly, promising results have been shown using estrogen in depression in perimenopausal women, so women at the menopause. So there is not just a theoretical aspect here, but there's actually a practical application of a treatment modality in estrogen. So let's look at more detail about these three depressive disorders and perhaps estrogen treatment. And here is a sample of some of the types of treatments that are available in Australia, and most of the world have variations of these hormone contraceptives or hormones used for menopause treatment. So what is PMDD? Premenstrual dysphoric disorder, which is actually depression. And this is another point that I want to make. Women's mental health conditions are often given a less important title. So, for example, dysphoria is the old term for sadness. And if you look at the term premenstrual dysphoric disorder, it kind of makes you think that it's not as significant as a major depression, which is downplaying this condition, but it actually is a significant major depression. So let's have a look at menstrual disorders. There are real premenstrual or menstrual cycle related mood disorders. It's not made up. It is not fake. It is a real thing. And 80% of women of reproductive age, 80% of all women of reproductive age have some issue related to menstruating. 40% have premenstrual syndrome, which is different to this, and 10 to 15% have PMDD. Premenstrual syndrome is where there are more physical health symptoms. So prior to having a menstrual period, many women with PMS have fluid retention in that they have sore breasts, they have fluid in the ankles, fingers, rings can be too tight, they have headaches or migraines get worse, and they can be irritated or irritable. That's pretty much it. Whereas premenstrual depressive or dysphoric disorder is a full major depression, and it is very different to just having PMS. So let's be clear that there is a commonality, but they are different conditions. The other thing that's important to say is it sounds like, and the textbooks will say PMDD must not be diagnosed unless there is only in 1 week prior to the menstrual period that the depression comes on. But this is a bit wrong, because in fact it predisposes the thinking that all women have a 28-day cycle, and that there is ovulation at day 14 in the 28-day cycle, and that in the week before menstruating, the depression occurs. That's not how it happens in reality. What we do know is that patients who have PMDD, women who have PMDD, have a story of a cyclical depression. They will tell you that the depression comes on, it comes on suddenly, and it comes on once every 4 or 5 weeks, but it also has a sudden offset. Now, the offset of the depression, or stopping the depression, may be when she starts having a period, or it may not be. But the key features here is that there is a cyclical onset, and there is a rapid onset as well as a rapid offset. That's what we need to look for. So what are you going to do when you have to treat PMDD? Well, PMDD, but not PMS, is not going to respond to vitamins, herbal treatments, or lifestyle changes. PMS, the premenstrual syndrome with the physical symptoms, does respond to vitamins, herbal treatments, lifestyle changes such as exercise and so on. But for PMDD, this is the full-on severe depression, and it does have suicidal ideas and very serious depression. Really, it seems obvious that we should go with a hormone treatment as our first line. And the oral contraceptive pill makes sense. This is a reproductive age group of women, and so it is not a big deal to use an oral contraceptive pill as a treatment here. So over time, we have done research which shows us that, in fact, we've got one pill, which is our favorite, called Zoli, which is natural estradiol plus nomigestrol acetate. If you're not in Australia, I'm not sure if you have this particular pill. Some countries do not, so we know it's difficult to get in the US, and we also know that New Zealand does not have this pill. Most parts of Europe do. I'm sorry, I don't know about India. But it is a combination of natural estradiol plus nomigestrol acetate, and we favour this because this is a mood favourable pill. It is not universal. There are many pills that actually can cause the depression because of the type of progesterone in it. So there are some pills where the woman has actually been fine until she starts the pill, and then she gets depressed. So having started with a hormone strategy, and it's not a very complicated strategy, it's using the pill. The other treatments that we use in my clinic here is that we sometimes add extra estrogen and try that. If that's not fixing the problem, then we add an antidepressant, or we have stepwise progression of treatments to the very complicated treatment that I work with endocrinologists, which is to organise a chemical menopause by using this particular medication. But what I want to make clear to this audience is when a woman says she has PMDD, or she tells you cyclical story of the depression, it's important to recognise that this is a brain hormone condition. I see too many sad stories of women who at the age of 23 have had a total hysterectomy and removal of ovaries to fix the cyclical bleeding, and of course in the mistaken belief that this will fix the PMDD. It will not, because PMDD is a brain condition. So I want to move to perinatal mental health. So perinatal, as it sounds, obviously is around the pregnancy and giving birth and the early period after giving birth. And here's some horrible figures, actually. Anxiety and depression are very high in pregnancy. Depression occurs in about 12% of pregnant women worldwide, and the anxiety rates are much higher, although less well studied, but it's anticipated that about 60% of pregnant women, 60% have anxiety of some sort. Now, those numbers, of course, come to us from different studies around the world, but by and large, the common theme, forget the numbers for a minute, but the common theme is that there is a high proportion of mental health problem in perinatal women. And the issues are twofold. One is that there can be new mental illness where there was nothing before in pregnancy, but there can also be a relapse in the woman who has a pre-existing mental health condition during the perinatal period. And unfortunately, the sad thing is that all of these mental illnesses can lead to mortality via suicide. This is Australian data, and again, the Australian government actually called for a special inquiry into suicide in a perinatal period of time. And the awful truth is that suicide is the leading cause of death for women during pregnancy and within 12 months of the end of a pregnancy. So as modern obstetrics and medicine has improved, that in fact the perinatal or pregnancy health conditions have improved enormously, and the death of mother and child, or mother and baby in childbirth is very small now, except that this is a problem that has been somewhat hidden and not recognised before this particular committee published their results, although many clinicians had, very much aware of the fact that this is a leading cause of death in Australia. Why is there such high perinatal suicide rate due to mental health conditions? Well, the range of factors is vast, and it's because, again, associated with pregnancy, birth, and parenthood, which of course has its joys and is a happy time, there are also psychosocial stresses. There are many stresses. And in women who are taking medications for previous mental ill health conditions, sometimes they are stopped because the medications or they're changed because of safety concerns about harm to the fetus in pregnancy and breastfeeding. The decreased medication can, of course, then change during the pregnancy, because there are a lot of physical health changes in pregnancy, and so medication absorption and so on can alter its efficacy in the mother. And there are big hormonal changes. Remember what I said, there's even specific estrogen that is produced by the placenta. So here again, you have fluctuations in the gonadal hormones that can affect the brain in terms of affecting the mother and her mental health. And sleep deprivation is very common in pregnancy and the postpartum period. And of course, we know that sleep deprivation is a potent bad factor for mental health. And the sad thing here is that there is a noted increased amount of domestic violence that occurs in pregnancy. And of course, that is very damaging in so many ways, as well as potentially having a mortality as well as morbidity. So there are many things afoot to try and address these issues. There are some excellent screening organisations in Australia, and there are good psychosocial support that is going on with the research behind it. But, and this is my particular concern, that we do not have a lot of causality research. That is why is this particular depression occurring at this point in time, and how do we then help to treat it? Because it's a specific type of depression that is occurring in the pregnancy and the early post-delivery period. And this is where the neurobiology or brain biological research is urgently needed. Most of the fields in medicine have made huge advances through the greater understanding of biology. If we look at our cousins working in cancer, working in stroke management, and look at the vaccine development, that whole story for COVID in the early 2020, everybody was saying, oh, no, there'll be no vaccine. You can't develop a vaccine because this is an mRNA virus. And yet with investment in the biological, molecular biology particularly, vaccines became developed. This has happened in every field. Cardiology, there is brilliant work that is being done in terms of being able to help heart attack victims and so on. Anesthetics and obstetrics. But what in psychiatry have we advanced in the field of brain biology to help us to actually develop new treatments? And I think psychiatry struggles with this lack of neurobiological knowledge. In the absence of neurobiology, psychiatry has focused on psychosocial therapies and support services, which are no doubt needed. But we still have issues with poor diagnoses, with missed diagnoses due to euphemisms such as the baby blues. Baby blues was the term that was used to actually describe the full-on depression that occurs after a woman has a baby. It's not just feeling blue. I go back to with premenstrual dysphoric disorder. It's not just being a bit sad. It is a full-on depression. We also do not have biomarkers that we can measure to actually diagnose the conditions objectively. Now, I don't expect you to memorize this, but what I put this up here to show you is that in a pregnant woman, there are 3 lots of active hormone producing organs. There is the maternal brain, the woman's brain, where there is a whole range of the hormones that I talked about, as well as the important downstream effects of these hormones into the placenta and the baby. So she's producing her own hormones. Then we have the placenta. Now, more recently, it has become clear that the placenta is actually an organ of its own, and it has its own brain. And so before, people thought the placenta is just a transfer of the nutrients that the mother takes in and transfers it through the placenta to the baby. No. As we learn more, we find that in fact the types of hormones that are produced in the placenta itself are very similar to what is produced in the brain of the mother. And then, of course, we have the third brain, which is the brain of the baby. So all of these brains are interacting continuously throughout pregnancy. And it is no doubt important in the mental health of the developing fetus, as well as the continuing good mental health, we hope, of the mother. But you can see that the mother is, and the baby are impacted by this third brain. So just to reinforce that the placenta is another brain, that the fetus, placenta, and mother are interdependent but functioning together as a unit, and they all have steroid biosynthesis leading to the concept of the feto-placental maternal unit or the feto-placental unit, a third brain. It's fascinating because no other time in the adult life does a person grow another organ with its own brain function. So this is the only time in an adult's life that you grow an organ. You do not do that any other time. So it's not surprising when I talk about the hormones have an impact on pregnancy. Think about all these hormonal signals and all the controls that are happening of the hormones on the chemistry in maternal brain, also in fetal brain. And, again, we know that what can happen is things that are going on in the environment of the mother can then set up different signals and different neurochemistry into the placenta and the fetal brain. So there are changes in the mother's brain that are caused by the fetus and that are caused by the placenta. And we always thought it was one-way traffic. We thought it was always mother, whatever she took in went to the baby. But of course, there is several traffic, and the traffic comes back from the baby to the mother as well. And we know this from immunology. So the mother in years and years and years to come will always, after pregnancy, have a genetic footprint of the fetus or her baby, because remember, only half of that baby is familiar to the mother. So half of the genetics comes from the mother, but the other half of the genetics in the baby comes from the father, and that is a foreign genetics for the mother. So there are all sorts of mechanisms in place that incorporate the foreign genetics into the mother and make sure that the baby is not rejected. It's a very fascinating area, but I don't have time to go into it in more detail. All I can say is, when we think about why do mothers get depression during pregnancy or postnatally when the baby's born, I'm surprised that it's, obviously not picked up, in terms of this kind of biology before, in times gone by, and that we've kind of discounted all of these major changes that are going on. And as we understand more about the neurobiology or brain biology and hormones and chemistry, I think we'll have a better opportunity to understand this very complex system and the conditions that arise, such as postnatal depression and postnatal psychosis. So again, why do many but not all women get depressed when you look at the complexity of what is going on? Well, it's because some women are more prone to hormone-induced mental health problems. There are some gene environment studies. There has been a gene isolated for PMDD, and we think that same gene is probably present in the menopause and perhaps in postnatal depression. So we know that some women carry this gene that is making them more prone or vulnerable to hormone-induced mental health problems, but that it requires a bad environment situation to bring this out. So women living in violent situations or high-stress workplaces or in complex family situations may well develop the mental health problems of depression or psychosis or anxiety disorders if they have an inherent genetic vulnerability. But how it is expressed, whether it's expressed as a depression or anxiety or what symptoms, will vary from woman to woman. So there's lots of work to be done here. Clearly, you can see that this is a whole area of research that we're undertaking and looking at new hormone strategies in postnatal depression. We're working with allopregnanolone derivatives and so on. We're using transcranial magnetic stimulation treatment in pregnancy and postnatal depression. And that's just some of the things that we're doing in the perinatal area. Because we're all looking for this outcome: happy, healthy mums and babies. I want to quickly move on to perimenopausal depression. So now this is a condition that I will boldly say is under-recognised and underrated. Middle-aged women are a high-risk group for developing clinical depression, and depression is the first and most common symptom of menopause. I wrote an article for Nature Outlook, and it was to basically say that there was the misunderstood female factor in midlife depression in women. And it's unfortunate that, a woman in her mid-40s can begin the depression as the first symptom of menopause. Menopause is a 10-year process, and it is critical that if depression is occurring, that it is treated properly, because it's not good to say, well, just wait until the menopause settles down and everything will be fine. You're talking about a 10-year, potentially 10-year condition, and a lot of damage can be done to her quality of life if this is not picked up and treated. There's a very high incidence of first-time ever depression in perimenopause. So, this is about women who have been totally fine for all their life in terms of mental health, and they have a nice social context, they're functioning very well, and then suddenly, about 43 years of age, they develop depression for the first time ever. There is even a higher relapse risk of women who've had depression in the past and been treated quite well, and then suddenly that all disappears and they become very sick. There is a 16-fold increase in depression in this midlife group, 42 to 52-year-old women. And in Australia, the second highest suicide group, demographic group, is women. The highest is in men over 84. And it doesn't take too much to when you know the brain biology, to say, look, the big X factor here is that there is chaotic gonadal hormone function in the brain because of the menopause process that is occurring from age 43 to 55. The brain changes happen first. They happen much more quickly before the hot flushes. It takes another 5-6 years before women have hot flushes and stop having menstrual periods. That is obvious once those things happen, that menopause is happening or happened. But the problem is that the brain changes insidiously begin much earlier, and therefore it can be missed that this particular depression is a different depression and it's due to the menopausal process. So to do this, I've developed a new rating scale for perimenopausal depression called the MENOD. And we found, using a range of different research methodologies, that there are two groups of menopause depression, as I mentioned: women who have an exacerbation of a pre-existing mood problem, and then women with no previous history at all. The other difficulty is we can't do hormone lab investigations. There's no point, because that is just a peripheral sample. It will not tell us what is happening with the brain estrogen fluctuations. So how to treat this? Well, I think we need to get better at treating this with hormones. Up to this point, standard antidepressant treatment is the guidelines first resort. But in fact, it's been shown that the antidepressants are only partially, they're not completely useless, but they're only partially effective. Whereas if you get the right combination of hormone treatment, common sense, it's going to treat the cause. So again, it is important that we look at that. So our research is looking at the recognition of the condition, safer, shorter hormone treatment, different antidepressant approach, and we're working with natural medicines and physical health overviews as well. So I quickly want to talk about violence against women. And we find that, 1 in 3 women experience violence at the hands of a partner. The darker colours in the spectrum of lighter yellow through to the darkest dark of purple is indicating more violence. So you can see that most areas of the world there is some violence, and some parts of the world have considerably more violence against women. That's domestic violence. And of course, one of the things that is important to understand is that, again, women's brains are more sensitive to the impacts of trauma because of the complex environment brain interactions. It is much more pronounced in women that in a traumatic violent situation, there will be a bigger reaction in women's brains of the changes in the neurochemistry. We think this is because women have got a greater sensitivity to perceive violence and also other things in the environment in order to be able to keep vigilant for child rearing purposes. This is an ancient sort of development in terms of evolution. Lifelong mental illness can occur as a result of early life trauma, and that's important, that we need to actually protect and prevent long-lasting mental illness by protecting and ensuring that our children have a very positive early life experience. And complex post-traumatic stress disorder is very common in women. It's about 4 to 1 times more common in women compared to men. What is complex post-traumatic stress disorder? This is a syndrome where there's difficulty controlling emotions, feeling very angry or distrustful towards the world. There are constant feelings of emptiness or hopelessness. There are a feeling of being permanently damaged or worthless, feeling completely different to other people, having an associated anxiety or depression, and both of those can be very severe, and also having suicidal thoughts and attempts at suicide and completed suicide. So again, there is PTSD, post-traumatic stress disorder, which is usually the term given to a single traumatic event, usually seen in the soldiers, for example, who in a war situation, the bomb may go off and that is a single traumatic event, and then they develop PTSD. Complex PTSD is caused by long-lasting, perhaps not obvious things like a bomb going off, but it is typically the result of childhood trauma, Unfortunately, it's not recognized in the DSM or American system of classification of disease yet. Women with this condition are often blamed and poorly treated, and a paternalistic approach has seen this behavior of difficulties of controlling emotion and some of the other things I mentioned as having a personality disorder or being willful or behaving badly. The personality disorder is a very harmful, stigmatizing condition diagnosis, and in particular, borderline personality disorder is sometimes confused with this condition or used instead of this term. And it is really awful when that happens, because it does not recognize that this woman often has a terrible early life story and is often the survivor of abuse. And so instead of being compassionate towards her and helping her, the condition is somehow treated as her fault and that she should just behave better. What's the cause of this condition? Usually the history of childhood trauma, actual cruelty, neglect, or brutality by the parents in many situations. And then there is a genetic vulnerability as well. And so you combine that with the maltreatment, and maybe there's another stress that happens in school, bullying, or other things that happen, and then the brain processes change, causing complex PTSD. And the important thing is about PTSD, or CPTSD, I should say, is that the stress in early life can create all sorts of physical health problems. So we note that, in fact, stress in early life changes the immune system so that there are many more allergies, there are many more infections, there are many more autoimmune diseases like irritable bowel or joint problems with sensitivities in terms of fibromyalgias and so on, that occur because the stress in early life has altered the immune system. There are also neuroendocrine or hormone changes. So this is where PMDD, premenstrual depression, and perimenopause depression, and polycystic ovarian syndrome are much more common in women who have early life stress or chronic stress. There is also anxiety, because the adrenal axis is dysfunctional too, and anxiety is a constant feature of complex PTSD. And there can be cognitive symptoms, poor self-esteem, a sense of not being worthy of a good relationship, and deliberate self-harm related to early and continuing stress in the environment. So this is what I mean by biopsychosocial. Here's the biology, the cortisol dysregulation in response to social or early life environment, leading to more biological changes and also psychological changes. They are all interrelated. And we're working on the new system that we've found to be implicated with complex PTSD. This is not going to respond, as many people do get given Prozac or SSRI drugs, antidepressant drugs, but they don't work very well in this condition. So we are working on a new system, chemical system called the glutamate system, that we think is more responsible for the CPTSD symptoms. And we've got some success stories there. So what is the treatment of CPTSD in women? Well, I put prevention of violence against women and girls 3 times, because that is clearly what we need to do. But then psychotherapy and biological new treatments that we're developing, such as with memantine, a new medication that we're using here, may well be implicated and helpful down the track. So I'm going to conclude soon because time is running out. But where to from here? Well, we need to understand that one size does not fit all. What works for a man may not work for a woman, and what may work for a particular type of woman in terms of treatment may not work for another woman. So we need many more different types of fitting the treatment for the specific person in front of us. And women need specific new approaches. Women with lived experience, that is the women with the actual conditions, are demanding new approaches, and we're really we love working in co-design with women who have lived experience. COVID, of course, intensified mental health issues for women globally. So there is a lot more work that needs to be done. Structural advances are important. So governments love building clinics or hospitals, but they don't really think about what the content is. We need new content to put in these structures, new causes, or a new understanding of what has caused the issues, new treatments tailored for women. And I think biological research has many answers. We need much more investment in women's mental health. We have developed a short course, so if you're interested, this is the short course, which contains a lot of the things that I've been discussing with you today. And we are working hard, and I invite you to work with us to make women's mental health a real priority and to do it now. Thank you for your attention.
Thank you so much, Professor Kulkarni. That was a brilliant presentation, and I definitely learned so many new things from it. So let's have maybe a couple of minutes of Q&A before we finish up. If anyone has any questions they'd like to ask Professor Kulkarni, please feel free to submit it into the Q&A panel below. Otherwise, I've got a couple prepared. So my first question is, what are some of the key factors that contribute to the underdiagnosis or misdiagnosis of mental health conditions in women, and how can healthcare systems address these challenges?
I think one of the big factors that is about the underdiagnosis of this sort of condition, which is the hormone impact, is that we tend to operate in a very sterile atmosphere, in the sense of, if you are a mental health clinician, you will just look at the depression and the psychological aspects thereof. Or, for example, you will not really think about things that are not in your usual domain of working. Whereas if you are an endocrinologist or an obstetrician or gynecologist, you'll think about the hormones, but you won't think about mental health. So this is one of the problems, that we're not actually integrating our health knowledge to then provide holistic care for women. The other thing is, we have got ourselves into a situation where it's called the gender blind approach to mental health. We don't tend to think about women as being different from men, or men being different from women. And we need to do that, because otherwise we are missing the best opportunities to really do things better for both groups, actually.
Yeah, that's a really great point. I guess GPs then, right? Like, usually people go to your GP as a first contact.
Yes. And the problem the GPs are wonderful, and they do as much as they can, but the problem is they're very rushed, don't have a long period of time to be able to do the sorts of work. So, for example, somebody who has a domestic violence situation, to earn the trust of that woman, to allow her to discuss those issues, will in itself take a long time and a lot of skilled work. And so, unfortunately, our poor general practitioners or primary healthcare practitioners really are rushed and often don't have the space or time to be able to do these things. But yes, they're in a good position for holistic care.
We've got a couple of questions from our audience. Quite a few, actually, so we probably won't have time to go over everything. Okay. But if you're happy to take questions beyond, maybe people can email us at admin, and then I can forward that to you, only if you're happy to.
Sure.
So one is, can severe anxiety be a key feature of PMDD without the depressive symptoms, the sudden onset and then gone with the hormone shift?
Yes, absolutely. And again, the key features to look for here are the sudden onset and the sudden offset. It doesn't necessarily have to be the crushing despair and depression. It can be severe anxiety, but look for the onset and the offset, because we all know that mental health anxiety or depression caused by stress in the family, in the work, or whatever, it doesn't come and go. You know, it's not on off. It is consistent, and it may be getting worse. So when you get that on-off picture, you have to think, what is the biological switch that is causing this? And so it's worth trying something like the oral contraceptive pill as a treatment, because that's not such a complicated treatment, really. So, yeah, we just got to think differently.
And How do you identify early signals of depression for women in premenopausal stage?
So this is in the early menopause, I presume. It is difficult because she still has a regular or regular-ish cycle, menstrual cycle. But what you look for is a change in mental health that cannot be truly explained by a whole bunch of stresses in her contextual life. And I find that most women, by the time they get to their mid-40s, they're very good at knowing, I've dealt with the difficult boss at work, I've dealt with the nasty mother-in-law, whatever. I know what that feels like. This is something different. And you get that story about the depression that is occurring in early life. Also, along with that, in the perimenopausal phase is an increase in weight, even though there's no change in appetite or eating or exercise. If you get that story of increased weight, that is another pointer. And plus, the quality of the depression can be that she suddenly is very angry. It's not the depression where people can't get out of bed per se. I mean, it could happen, but that's rare. It's much more the angry, hostile sense of just, I can't handle this. Why are you being such an idiot? That kind of irritability towards family or co-workers and so on. So there's a different quality. But I think just go back to the woman herself, because most women at this stage of life are pretty good at knowing that's because of that, or this is something else. So we need to hear that.
And final question. Lynn has asked, as a general adult psychiatrist, can I ask your advice about prescribing memantine for CPTSD outside of research parameters? I also have a deal of frustration with GPs being reluctant to prescribe HRT for mental health issues at menopause. What advice would you have for psychiatrists regarding prescribing HRT?
They're fantastic questions, Lynn, and I share your frustration. Let's take the HRT question first. So unfortunately, in 2001, there was the Women's Health Initiative study, which has been debunked, but that study came out saying that HRT was bad in terms of causing breast cancers and so on. That is complete nonsense. It has really been debunked. But unfortunately, a lot of GPs particularly have stayed with that old information from 2001, and now we're 22 years later, they're still using that. So I think I actually am happy to prescribe HRT as long as the GP is doing the follow-ups of patients. However, if the psychiatrist is not happy to do that, then you're going to have to find a GP that the patient can work with. And if the GP is so adamant that they're not going to prescribe HRT, then the patient has probably already decided that she's not happy with that GP. And there are now emerging women's health clinics, which are good because they're GPs who are trained in women's health. So the only times you can't prescribe is in people who have physical health contraindications for HRT. Memantine can be prescribed as an off-label prescription because it is a drug that is available. It comes to us from Alzheimer's disease. It's been used in elderly people with Alzheimer's disease for a long time. So it's a known product. And in fact, it's been used in very elderly, frail patients. So we know that, in fact, in a younger patient, it's not going to cause problems. It has very few side effects, but it's an off-label prescription. So again, it is possible, and we've seen people take it. The patient's usually very willing to try things with CPTSD because she often feels just so miserable that she will try this, and you can, do that as an off-label prescription.
Wow, thank you very much, Professor Kulkarni. It's been such a fascinating topic, and I feel like I could listen to it all day.
Well, I've got a lot more to go on with, so I'm sorry I've probably gone way over time, but
that's okay.
There's a lot to talk about.
Yeah, I think a lot of our audience might be signing up for that training program that you
please do
put at the end. All right, so on behalf of the MHFA, we sincerely thank you for taking the time to present today's webinar. Again, it's been such an honor to hear from a prominent figure in the field, and we look forward to future opportunities to collaborate again. And I now invite Dr. Naren from Dr. MGR University to deliver the word of thanks.
Thank you.
Mm. Uh, Hello.
Hello.
Yes, I'm audible. Yes. Yeah. So hello everyone. I'm Naren, Dr. Naren from Dr. MJ University. So I would like to uh, on behalf of the Department of Psychiatry, I would like to thank the respected Honorable Founder Chairman Dr. A.C.S. Shanmugam sir, and our Honorable President Dr. A.C.S. Arun Kumar, and our beloved Vice Chancellor Dr. Geeta Lakshmi Madam. I am privileged to thank our speaker Professor Jayashri Kulkarni ma'am, and I for your enlightening speech on especially a very important and a common issue all over the world, and particularly on your focus on integrating biologicals and neurobiology in addition to a holistic approach. It is very enlightening, and thank you for that. So I would also extend my sincere thanks to the MHFD members, especially Dr. Vasan Srinivasan, and coordinators Dr. Mr. Akshay Subramanian and Aura, and also Nitya Vishwanathan, and also extend my thanks to Kalai Mamani, Dr. Amuda Kumar, consultant from Mehta Multispecialty Hospitals. I'd also especially thank our respected dean from our university, Dr. Balasubramanian, and Dr. Kausalya, who's the Dean of International Relationships Coordinator, and also Dr. Sendil Nathan and Dr. Manivana, the Joint Register. I especially thank our fellow participants here. I hope you had an enlightening session on in age where a stigma on women are particularly increasing. So I would thank the IT department from this institute for the support, and thank you one and all.
Thank you, Dr. Naren.
Yes.
And if everyone would like to re-watch this webinar, the recording will be uploaded to our YouTube channel. And if you'd like to contact us further, you can email us at admin@mhfa.org.au. That concludes today's webinar. Thank you all once again for attending. Bye for now.
Thank you.